Welcome to AETCM, the Emergency Medicine channel. Myself, Dr. Naveen Mohan, HOD of Emergency Medicine at AIIMS Kochi.
I'm Dr. Shreya, first year PG resident.
I'm Dr. Priti, first year PG resident.
So we'll start, sir. A 42-year-old male came to ER with deviation of right side of angle of mouth since 3 days. On initial 10-second assessment, patient was speaking in full sentences, airway was patent, breathing-wise, respiratory rate of 18 with a saturation of 97%, circulation-wise, BP of 160/100 with a pulse rate of 98 per minute. Disability-wise, GCS was E4V5M6 with pupils bilaterally equally reactive. Exposure-wise, patient was afebrile with a GRBS of 180 mg per deciliter. So we went to sample history. Patient, actually a 42-year-old male, came to ER with complaints of dribbling of water from his mouth while trying to drink 3 days back, following which he noticed that the right-sided deviation of his angle of mouth. Patient also had complaints of painful vesicles in the inner part of the left ear since 3 days. There was no complaint of any fever, any vesicular rash on the tongue, buccal mucosa, on the palate, any hearing loss, any discharge from the ear, any hyperacusis, any vesicle on the lateral part of the neck, in the ovula, in the pharynx, or any rash on the body. He had complaints of ear fullness, but there is no history of any limb weakness, any slurring of speech, or any gait ataxia. Allergic history, he is not allergic to any known substance. Medicine history, patient is on cyclosporin ear drops for the last 6 years.
Any history of trauma?
No history of trauma, sir. He has no known comorbidities, but he had underwent corneal transplant for keratoconus in 2018, for which he is on immunosuppressant eye drops. Last meal was 2 hours back. So we went ahead with examination of the patient.
So basically, this case is right-sided deviation of angle of mouth deviation, and in such a case, after your primary survey, once the patient is stable, your main focus is to assess whether the patient is having a UMN facial palsy or an LMN facial palsy. If it is an UMN facial palsy, it means stroke.
Stroke, yes, sir. Central cause.
Okay, from the emergency perspective. Whereas if it is an LMN facial palsy, what is your diagnosis?
Sir,
what all things should come into your mind?
Yes, sir. So any acute facial palsy, sir, it could be central cause, it could be peripheral cause. In central causes, we will have stroke, any SGH or any tumor. Other than the face, other motor deficits will be present. In case of LMN causes, which will be the peripheral causes, will be multiple factors like infective causes can be there, such as otitis media, cholesteatoma, malignant otitis externa, any Lyme's disease, viral infections like herpes simplex virus, cytomegalovirus, Epstein-Barr virus, then parotid pathology can be there.
So did this patient have any history of chicken pox in the past?
In childhood, no, sir.
No,
sir. In parotid pathology, there could be parotitis, any malignancy of the parotid gland, then any trauma, facial trauma to the patient, then any neurological causes such as multiple sclerosis, Guillain-Barré syndrome, any diabetic neuropathy, monopathy, or any vascular causes such as vertebrobasal insufficiency. All this could present as
neurological causes, vascular causes, infective causes,
and
any tumor
and trauma,
or any trauma. These are the major things. In neurological causes, GBS, multiple sclerosis, diabetic mononeuropathy because of a vascular insufficiency. Then in vascular causes is vertebrobasilar insufficiency. Then
infective causes.
Infective causes is
it could be
herpes zoster,
Epstein-Barr virus,
viral
infections basically.
Okay.
Then sir, any parotid malignancy.
The sarcoidosis
Sarcoidosis can be there.
Lyme disease.
Lyme
Right.
disease,
But for Lyme disease, you should have rash and did he have any rash on the body?
Rash. No rashes on the body, sir.
All right. Then what else?
Any parotid pathology, parotid malignancy.
Malignancy or tumor. Okay.
And trauma.
And then
Direct trauma.
So these are the things should be taken into consideration. If all these things are ruled out, then what is your diagnosis?
It is a element palsy. If
Well,
all
idiopathic
idiopathic
palsy, which is also called as Bell's palsy. In such cases, you are supposed to give what treatment for Bell's palsy?
Steroids is the first
Steroids.
line of treatment.
Okay.
Yes.
Whereas if it is,
Physiotherapy.
how much of steroids will you give?
So we'll give 60 mg of steroids for 10 days, sir.
Oh, tapered, no?
Yeah, 50
Slowly
mg, 50 mg for 10 days or 60 mg for first 5 days, and then we can taper over
taper
the
down.
period of
Alright.
10 days.
Okay. Whereas if it is another cause, treat the underlying
To treat
cause
the
of
underlying
the
cause.
Bell's palsy. If it is because of a, so you told some rash is there on his this thing.
His inner ear, he
Inner
had
ear
some
and
painful vesicular rashes with
so
us.
that then your diagnosis will be to what will be your diagnosis?
So,
Bell's palsy with the rash means ear
like most common is
Ramsay Hunt. So what is the treatment for Ramsay Hunt?
So it has to be viral, acyclovir, that is antiviral with steroids, sir.
Antiviral. So how many? What is the dose of what antiviral will
You
you
can
give?
go ahead with acyclovir, sir. It is 800 mg TID 5 times a day for 5 days, sir.
Okay. Or valacyclovir also.
Valacyclovir, ganciclovir can also be given.
These things can be given along with steroids, right?
Along with steroids. Same dose,
Okay.
50.
But the treatment usually what they say is within the presentation within
72
hours. But this patient came
Within
after
70
within 72 hours.
Uh,
All right. So you can start. Theoretically
initiate
speaking, you
the
can start. Okay. All right.
Then we went ahead and examined the patient, sir. On examination,
But history-wise, you think it's purely
it is
LMN,
element Palsy
not
because
UMN at all. No weakness,
patient did not complain
no
of
other
any
symptoms,
weakness.
no other neurological symptoms which suggest a stroke
no weakness,
or a tumor,
no
nothing.
swelling, no,
Patient had no history of fever also,
no history of fever at all, sir.
no weight loss, nothing.
So, going ahead with examination, we went ahead with the neurological examination first. Since we were suspecting an element palsy, because patient had no other complaints other than that water dribbling down while taking water, we went ahead with examination. We asked initially to patient to raise the eyebrows. Patient initially when we tried looking for any wrinkles on the forehead. The wrinkles were absent on
It's
the left
cranial
examination. We went ahead.
your focus is this is a CNS examination
Yes,
case, but your main focus should be on cranial nerve.
Cranial nerve, yes.
Okay.
So basically,
Even in an OSCE exam, your station will be patient who has got some discomfort on the left side of face, some left side weaknesses felt like that today early morning, and right now you do a cranial nerve examination. That will be your Markham OSCE station.
Okay.
The entire CNS examination will not be asked.
Okay, sir.
Okay, because that station itself will be around 7 to 10 minutes, and you can't complete the entire examination in that way. So cranial nerve, solely on cranial nerve will be asked for. Okay.
We went ahead with the cranial nerve examinations, and since suspecting element palsy, we initially ruled out we started with testing with the seventh nerve. Initially, we asked the patient, he was not having any other complaints other than just this dribbling of water that he noticed 3 days back. So, cranial nerve 1, we usually ask patient whether patient has any olfactory senses, any altered sensation or anything, not getting smell. No such complaints. Then on
So ask you, can you smell this? Can you
patient
smell
did not
that?
have
Okay.
any,
So cranial nerve olfactory
olfactory is ruled out.
ruled out.
Then
Now,
coming to cranial nerve 2.
cranial nerve 2 already.
Cranial nerve 2, we inspect the pupils. We see the size symmetry.
Some coffee or something you can give for
Just
smelling.
any
whether you
incense
see-
stick or any
Pardon?
incense stick or any this thing that can be given.
Yeah.
Any perfume that can be asked
perfume
to
or something
smell.
you can give and rule out.
Cranial nerve 2, sir, we have to inspect the pupils, the size,
That is
shape,
cranial 2
symmetry.
means
2
optic.
is optic nerve, sir. Optic nerve, we have to go ahead with the size, shape and symmetry of the pupils. Then we have to check the visual acuity of the patient, which is done using Snellen's chart. If we have a Snellen chart, we have to ask the patient to read out the chart by standing at the distance of 3 meters from the patient. So the lowest
Basically checking for visual acuity.
visual acuity, how sharp
Far
is the
vision
patient. Far
and near vision.
both.
Can you? This is a Snellen's chart. Can you see this?
Yes.
Can
And
you
which
can
lines
you
we
read the
can
last
read.
line here?
Yes.
Here.
Yes.
Okay. Snellen's
Like
chart.
that.
Your far vision is checked. Now near vision. Can you read this?
Yes. Okay.
Done.
After that, sir, we have to see the direct and indirect pupillary reflex, whether the pupils are
No.
constricting.
Visual field.
Then
Okay. You continue.
then pupillary reflexes we checked. After the pupillary reflex,
Pupillary
we go ahead.
reflex means direct and
We have to
indirect.
direct and indirect. Whether on putting light, this the direct reflex will be the constriction
How
of
will
the
you
same
check
pupil.
it? How will you check?
So we will make the room dark. Then we will put the light. We'll ask the patient to look straight, and we'll put the light from sideways. Suppose we are putting on the right side, right eye, the right eye pupil should constrict. At the same time, we should look at the left eye also, whether it is constricting
like
or not.
that.
There should be a hand in between.
You
Patient should
swing
put
a
his
light
hand.
here
Yes.
and see for
Both.
contraction in the other eye.
Side.
Okay.
So same side pupil contracting will be direct, and other side contracting will be indirect reflex.
Okay.
Then we ask the patient.
What is afferent and efferent for?
Efferent will be cranial nerve 2. Efferent will be cranial nerve 3. Then, sir, accommodation reflex we have to check. We have to ask the patient to focus on on the wall, suppose, and then suddenly focus on a finger in front of the eye.
Okay, just immediately. Whether he is able to focus on that.
So here we look whether there is pupil constriction and convergence of the eye is there or not. Then we go ahead with color vision. Color vision we have to check using Ishihara chart. Here we basically, if it is impaired, it could denote any vitamin A deficiency, any optic
also
neuritis.
swinging flashlight test.
That is for RAPD.
RAPD.
Which is for optic neuritis. RAPD, if we find, that means optic nerve is damaged. Any optic neuritis could be there.
All right.
So like that only, color vision also we see. Ishihara chart we ask. If Ishihara they are not being able to identify the numbers in the chart, we can suspect any vitamin A deficiency, any optic nerve damage, or any congenital color blindness in the patient. Then we can go ahead with visual eye field, visual field testing, sir. In visual field, basically, we have to close the same eye, the examiner and the
like
object.
This.
Same side eye has to be closed, and then we have to, from the 4 quadrants, we have to move the fingers.
From the center outwards, like here. Can you here, here,
Like
and similarly on the other side also.
yes. Same
From
side
the
eye
center
should-
out, out, like that. So all four
All
quadrants
have to be seen. Like when the patient sees the finger, he has to see. He has to mention. Then we have to also do fundoscopy in this step to rule out any papilledema, like looking for any optic neuritis, if possible. Then we go ahead with.
But
cranial
usually in your cranial nerve exam, in your Markham OSCE, the examiner will not ask you to do a fundus examination. You can just say, ask whether I should go ahead with the fundoscopy. Usually they will say no, because this fundoscopy examination, that part itself is a separate station.
Okay.
Okay.
And going ahead with cranial nerve 3, 4, and 6. That is the ophthalmic nerve and abducent nerve and the trochlear nerve. Here we check the eye movement, sir.
3, 4, 6 together.
3, 4, 6 together we have to move. We have to see. So these are, we make the pattern H.
H. So like this.
Yes. We see all the.
And here also you can just look up, look down, like here, like that.
Yes, sir. So here we look for any gaze palsy, any nystagmus is there or what. We look for ptosis. And then we also look for the corneal light reflex, whether it is symmetrical or not. Then corneal light reflex, like whether the light reflex falls in the pupil, it's symmetrical or not. Alignment is there or not, we check for. Then we can also do cover uncover test.
Whether the patient has got, while doing this, you should be checking whether the patient has got
Any restriction of
any
movement.
diplopia,
Any diplopia.
or pain or any restriction of movement. This patient may be, is there?
He did not have, sir.
He did not have.
No involvement, sir. Okay. And also we can do the cover uncover test. We can see if there is any strabismus, any strabismus, any squint is there, then we can identify. Because if we cover one eye, the other eye won't be able to focus. Then, sir, coming to trigeminal nerve, that we have a sensory component, a motor component, and jerks are there.
Okay. That means fifth nerve. Trigeminal is fifth nerve.
Fifth nerve.
Okay. So till now, the nerves which I've examined are out normal. Everything was normal in this case.
Yes.
Okay.
Then we
Trigeminal nerve.
come to the trigeminal nerve. Trigeminal nerve, the sensory component, we have to check by putting a cotton, the wisp of cotton, and we will check.
The trigeminal nerve has got 3 branches.
3 branches. So it will be V1, V2,
Ophthalmic,
V3.
maxillary, mandibular. V1, V2, V3.
Yeah, V1, V2, V3. So first
So
we
that
stress the
sensory part of the face is by the trigeminal nerve. It's not by the facial nerve.
So we take a wisp of cotton and then we initially ask the patient without closing the eye whether you can feel this or not, and then we ask him to close the eye and tell them that tell us whether they are feeling
you touch
or not.
here?
Yes.
Are you able to feel this?
Yes.
Are you able to feel this? Are you able to feel this? Bilaterally you check. All right.
With the same we do with a prick pin also.
Prick pin or neurotip?
Yes, neurotip, whether he can feel both sides.
Okay. So soft touch and hard touch. Okay.
Then we come to the motor. In motor, we are examining for the temporalis and the masseter muscle. That we ask him to clench the
Clench
teeth,
teeth.
and we feel for the muscle here. Masseter and the temporalis. And then we ask him to open the mouth against resistance.
Like this.
We'll hold from below. We'll ask him to open.
That is for
checking
pterygoid.
the lateral pterygoid muscles.
Okay. Okay.
Then we have two jerks here.
And this movement also.
The side-to-side
sides.
movements
All
on
right.
the jaw. Then we have to go ahead with jaw jerk and the corneal reflexes.
Yeah, now the reflexes.
Jaw
One
jerk
is
we
jaw
have to-
jerk.
We have semi-open the mouth, put the thumb on the mandible tip, and
tap.
then we
Okay.
patient will close the mouth. Then corneal reflex, we have to place a wisp of cotton at the nimbus, that is at the junction.
All right.
And then patient will have will close the eyes. That is the reflex we are expecting.
In this
And
patient,
this is intact, sir.
intact.
Intact. Then finally we come to cranial nerve 7, sir. That is the seventh nerve, facial nerve we are trying to examine.
Usually, I'm not sure whether this will be intact in this case because he'll be unable to close. Right? Orbicularis oculi will be gone, right? It is a.
In the sense, to
Even though he wants to.
the reflex is there, sir.
Reflex is there. Even though he wants to,
but,
this thing because his muscle is weak, probably he is not able to.
Open, like eye will be half open, like he can't close it fully.
all right.
But the reflex, like on touching it, he will be able to. Is there. So, then seventh nerve, we ask
That's
the
my
patient.
facial nerve.
Facial nerve.
Okay.
We ask if the patient is having any change in any taste since last few days, or there is any inspect for any asymmetry of the face. That is like we look for the forehead wrinkles, we look for the nasolabial folds and the angle of mouth. That is for inspection. Then we'll ask the patient to raise the elbow. Whether there is wrinkling or not, we have to see. If there is seventh nerve palsy, that side of the face will not have wrinkles. That side of the forehead, when he raises his eyebrows, one side will
So
not
if
be
it is
having
a seventh nerve palsy, element facial palsy, the upper part will be involved. Upper part of the face, the forehead will be involved. Whereas if it is a UMN facial
It won't
palsy,
be
the upper
involved.
part
Be
will
spared.
be spared.
Spared. Then
So this patient
upper part
was not able
involved.
to.
He was not. No wrinkles were there.
No
He was
wrinkles.
not able to lift the eyebrow.
So the basic muscles which supplied by the facial nerve are
So orbicularis, frontalis,
frontalis, orbicularis oculi,
and corrugator
corrugator
ciliaris.
ciliate. So unable to. Okay.
Lift. Then, sir, patient, we asked him to close the eyes. So, and we have to ask them to close the eyes, and we should try to open. But here in this patient was not able to close the left eye. He could close the right eye, but left eye he couldn't close. So this is because of the seventh nerve involvement.
So
that
what
is
is it?
suspected. So that is known as Bell's phenomenon.
Bell's
sir.
phenomenon.
Basically, we should be able to close the eyes, and when we try to open it, patient should have resistance so that we can't open. But in this patient, it is not closing because of weakness of this muscle.
Okay.
So then we have to ask the patient to blow the cheeks. If the patient is about to, if able to blow the cheeks, then seventh nerve is intact. But in this patient, the left side of the patient, he could not blow. Like air would come out whenever he would try to blow the cheek. Then ask the patient to smile. When he smiled, patient was having right-sided angle of mouth deviation. That is because left-sided weakness was there. Then we have cranial nerve 8, sir. That is the
So what is
vestibular
the facial nerve? What is the pathway?
pathway for facial nerve. So, facial nerve starts from the
So
original
facial nerve is
pons.
involved in this case.
Yes, sir. Facial nerve involvement. From our examination, that is what we found, sir. So, facial nerve starts from the pons, sir. From the superior salivary nucleus, it will start the facial nucleus, and then it will come out to the temporal bone, enter the internal auditory meatus. In the internal auditory meatus, patient will then enter into the facial canal, where there is the geniculate ganglion. From the geniculate ganglion, the greater petrosal nerve is given out. The greater petrosal nerve, it carries the secretomotor fibers to the lacrimal glands. Then from the geniculate ganglion, we have two other branches. One will come out as the chorda tympani, and then from the chorda tympani, we have the lingual nerve. These
Joins with the lingual.
lingual nerve. These carry secretomotor fibers to the submandibular and the sublingual gland, and the chorda tympani is responsible for the taste of the anterior.
That's why you are
prefrontal
checking
sensation.
taste for facial
Facial
nerve.
nerve.
All right.
Then this also gives out one, that is the nerve to stapedius, which could lead to hyperacusis if that nerve is involved. Then the nerve goes through the stylum.
These are the branches given off in the the facial canal.
In the
That
facial
means
canal
one is to the
itself.
lacrimal, the secretomotor fibers to the lacrimal gland. One is one to the this thing, submandibular and sublingual gland, this chorda tympani will be given, and that will join the lingual nerve. Secretomotor. Then the other one is nerve to the stapedius.
Yes.
Okay.
Then
And then after exiting the this thing, facial canal.
after exiting the facial canal, it goes into the stylomastoid foramen and then the parotid gland, sir.
After it exits through the stylomastoid foramen, enters through the internal acoustic meatus and exits through the stylomastoid foramen, and then it enters between the
Parotid gland, dividing into 5 branches.
Yeah.
These 5 branches are the temporal, zygomatic, buccal, marginal,
zygomatic, buccal,
marginal, mandibular, and cervical. And these are the branches which supply the muscles of facial expression. So that is the course of the facial nerve, sir. After that, sir, we were going ahead with the examination.
That is why the taste sensation, was it fine?
Yes, taste sensation was fine, sir. But his just this wrinkles and facial muscles.
So that means the issue should be outside the facial canal.
Yes.
If it is inside the facial canal, you should have that hyperacusis, stapedius, nerve to stapedius, taste sensation, secretomotor, this thing.
Watering should
watering,
be affected.
But that wasn't there. So it should be outside. So if it is outside, the question is whether the patient has got some tumor here, the parotid gland area, which is compressing the facial nerve. But clinically that wasn't there.
Clinically, no swelling noticed as such. He was also not complaining anything. Acute onset weakness only he complained of. Then coming to cranial nerve 8, sir, that is a gross hearing. Ear. That is it is known as vestibulocochlear nerve. So gross hearing assessment is done here. We will whisper a number into the patient's ear and whether he can hear it or not.
Before that ear examination should be done.
No, external ear.
Because he already told it there was some rash or somewhere here.
Exactly.
So that part has to be mentioned in detail. That ear examination itself is a separate station.
Okay, sir.
Just like a fundus eye examination, it's a separate station. Okay.
And then we go ahead with the Rene's test and Weber's test here.
But inspection wise, internal
Inspection wise, already there was vesicles inside in the inner part of the ear. Which were painful also.
Okay. No hearing issue as such.
No hearing
and
issue.
externally looking at it, you didn't have any like the otoscope examination. You didn't have any
any rupture of
features of
no swelling.
rupture. You're looking for acute otitis media.
No otitis media.
Cholesteatoma.
Cholesteatoma not there, sir. No hearing loss also. Just ear fullness he was complaining of. Ear fullness.
Okay. And no malignant otitis externa, nothing was there.
No, sir. No non-comorbs, not a diabetic patient.
Okay.
Then, sir, then we did
not immunocompromised also.
only topical immunosuppression he was
Topical
on.
immunosuppression.
Topical immunosuppression. Then coming to cranial nerve 9 and 10, sir, we have to ask if regarding any change in voice, any difficulty in swallowing. Then we have to examine for the uvula of the patient.
Eighth you have done a Rene's?
Rene Weber we have to do, sir. Rene Weber.
And everything was
Rene
fine.
Weber's air conduction more than bone conduction. Weber's was centralized, sir. Hearing loss as such not complaint. So, sir, coming to cranial nerve 9.
Whispering and all, close whispering, loud voice, everything was clear. All right.
So, cranial nerve 9, sir, there is no change of voice and there is no difficulty in swallowing as complained by the patient. On examination of the uvula also, uvula was central in position, not deviated to any side.
Right.
Usually, if there is involvement, uvula will be
You
deviated
say open
away.
your mouth, say and then ask him to cough also. All right.
Cough. If cough is impaired, that is vagus involvement will be the 10th nerve.
Uvula normally
Deviate away from the lesion.
away from the lesion. That is one question that they ask. Which side should be affected? Okay.
Then swallow test we have to do. Ask him to
This
swallow.
is you are
water
basically
this
testing
age,
which all nerves?
This is 9 and 10, sir.
9 and
combined.
10.
9 or 10th lesion, they will have cough reflex is for 10th nerve. Swallow water. Ask the patient to swallow water. That will be dysphagia.
Okay.
If patient is not able to, that will be either 9 or 10th nerve can be involved.
All right.
Then we have to also do a gag reflex if possible. Gag reflex will be the afferent will be the glossopharyngeal 9th nerve and the efferent will be the vagus nerve if it is impaired. Then cranial nerve 11, that is the spinal accessory nerve. Here we look for the trapezius muscle
Can I ask you to give some water also?
Water of the patient. Yeah, solid. We can ask. So then trapezius muscle, we have to ask the patient to shrug the shoulders against the
Like
resistance.
this, okay.
Yes. And then we have to look for the sternocleidomastoid strength. So we ask the patient to turn the head against a resistance. The prominence of the sternocleidomastoid on the opposite side will be there. Then cranial nerve 12. Cranial nerve 12 is hypoglossal nerve. Here we look for any tongue fasciculations, any wasting of the tongue, and any deviation of the tongue on protrusion. Usually the tongue will get deviated towards the side of the lesion if there is any involvement of the nerve. Here nothing as such was there. Then in this patient, sir, on examination wise, we found only cranial nerve involvement was there.
Other systems are all fine.
Other systems were fine. Systemic examination was within normal limits. Patient was not complaining of any motor deficit. There was no
all sensory motor, reflexes,
was,
everything. Other CNS examination, everything is clear. Only thing you found out positive, the seventh cranial nerve involvement with lesions
in the ear. So we provisionally diagnosed the patient to be Ramsay-Hunt syndrome.
Ramsay-Hunt syndrome.
And we started treatment on the same line.
Within 72 hours presentation?
We gave, in the ER itself, we started the patient on acyclovir 800 mg stat and steroids, prednisolone 60 mg stat was given, sir.
Okay. Even if it is you can actually discharge this patient with this thing, and some isolation will be required.
Yes, sir. Yep.
Because of its Ramsay-Hunt reactivation.
Basically, immunosuppressed pregnant patient should not come in contact with the patient.
Yeah. And the thing is, any case of Bell's palsy also you can discharge with steroids. But after 1 week, you should review in the with the local doctor, because you don't know whether it's maybe like these lesions will develop only after that. So you don't know whether initially you would have thought it is a pure Bell's palsy, that means idiopathic facial nerve palsy. But later on, some lesions will start developing, and then your diagnosis changes to Ramsay-Hunt. In that case, you should start on antivirals. Okay. That is why you ask them to review after 1 week. And usually, it's self-limiting; it gets resolved within
10 days.
84 days or something that Brett mentioned. That is how it goes. And for eye will be open.
Exposure, because patient will not be able to close the eyes. So that's for risk of exposure keratitis is there. That's why eye drops have to be given, and at night it's better to put a sleeping mask and close the eye. Otherwise,
every 1 hour or so you need to apply the
eye
drops. Night time you can apply some ointment and then tape it with the. That is how it goes. Okay, anything more? Okay. Thank you.